Very, very similar story with RIF, or recurrent implantation failure. Research has shown that there are altered cytokine profiles in RIF patients, that patients with RIF tend to have elevated pro-inflammatory cytokines and decreased anti-inflammatory cytokines, and therefore these increased Th1 to Th2 ratios. But there is not really that evidence there to support the routine use of peripheral blood cytokine levels to diagnose RIF or to guide immune treatments.
So this begs the $1,000,000 question, why do we do it?
Welcome to my fertility podcast, Superhumans.
A space for honest conversations, expert insights, and stories of resilience.
Whether you're just getting started on your fertility journey, facing challenges, or looking to educate yourself, you are in the right place.
We are Dr. Mavis Garcia
and Dr. Wise,
fertility specialists at Markham Fertility Center, located in Markham, Ontario, Canada.
Think of us as your biggest cheerleaders. Let's demystify the world of fertility together. Hello, everyone, and welcome back to another episode of my fertility podcast, released here again on another Tuesday. I'm Dr. Wise.
And I'm Dr. Garcia. And today we are continuing our series of episodes on the immune system and all the treatment options, by far the most requested topic that we get.
Absolutely, yeah.
We're going to be doing a deep dive today into the topics that generate so many questions, confusions, and honestly mixed emotion for patients. And this is the concept of cytokines. Specifically, when they're elevated, what does it mean in the context of recurrent implantation failure or recurrent pregnancy loss?
This is part 3 of our series on the immune system. Check out part 1, which is episode 78, where we talk about immune treatments and the immune system in general, and episode 83, part 2 of our series, where we talk about leukocyte antibodies and the treatment LIT.
We're going to do a bit of a recap. And again, you should listen to these episodes for more details, but we want to make sure that every episode does get a little bit of an introduction into what the immune system is.
Mm-hmm.
The immune system and the role in infertility and recurrent pregnancy loss is one of those areas in medicine where science, hope, uncertainty, and desperation, frankly, intersect. Many patients come to us after failed multiple embryo transfer of heartbreaking pregnancy loss, desperate, begging us for an explanation.
Often, when they've seen other physicians, other care providers, they've already been told or discovered through their own research that something called their immune system might potentially be the problem or might be one of the issues. So today we really want to slow this down, explain what cytokines are, why we're talking about them, why they're being talked about on social media, what the evidence actually shows, and how we approach treatment in what we think is a thoughtful, patient-centered way.
And as always, I know we said this before, but it has to be said again. Our goal here is not to sell you a treatment. It's not to tell you that immune systems or immune treatments are the answer to all of your problems, but to empower you with understanding. This is not medical advice for your individual case, but rather education so that you're informed about what conversations you need to think about with your fertility team.
First off, let's start by talking about what we mean by recurrent implantation failure and recurrent pregnancy loss, because again, those terms can be really confusing and they're defined differently in different sources depending where you look.
Recurrent implantation failure refers to the inability to achieve a clinical pregnancy after multiple embryo transfers. Usually when these embryo transfers involve good quality embryos, and very often now with the advent of PGT, genetically normal embryos. To learn more about recurrent implantation failure, you should listen to episodes 72 and 76.
There's no universally accepted definition for recurrent implantation failure or RIF, but many clinics, physicians will sort of use something like failure after 2 or 3 transfers of euploid embryos, or failure after several transfers, 3 or 4 of high-quality embryos, especially in younger patients.
Now, on the other hand, recurrent pregnancy loss is typically defined as 2 or more clinical pregnancy losses. Some definitions would say 3, but most of us really start evaluating after 2 because we know how devastating even having 1 or especially 2 pregnancy losses can be. Some definitions might also take into account the age of the egg provider and whether or not the losses were continuous one after the other or whether there were some life births in between.
Importantly, recurrent pregnancy loss can occur after a spontaneous pregnancy or after IUI or after IVF. And there are many patients who may experience a combination of recurrent implantation failure and recurrent pregnancy loss. We do a deep dive into recurrent pregnancy loss on our podcast on episodes 51 and 56. So please check those out if you want to hear more.
Okay, so back to our little biology lesson about what the immune system is and what is its role in pregnancy. Pregnancy is fascinating from many points of view, but especially from the immunological point of view. Because remember, the embryo is genetically at least half foreign to the body. Yet, in most cases, the reason that we're all walking around is that the immune system, even though it's very good at recognizing foreign bodies, is also very good at tolerating an embryo, even though it doesn't have 100% the genetic material of the person carrying that embryo.
And this requires a very delicate balance. We need an immune system that's not completely turned off, so to speak. And we also need one that's not overactive, but one that is appropriately regulated and appropriately regulated at the appropriate times. Because again, it'll change, it'll fluctuate over the course of implantation and pregnancy. We've previously talked about this being like an orchestra playing a symphony, where there are so many pieces that have to work together at the right times for success and for that magic to occur.
The immune system is divided into what is called innate immunity and adaptive immunity. Innate immunity is fast and non-specific. So this would be your natural killer cells, your macrophages, and the cytokines. Adaptive immunity is slower, more targeted, and it includes the T cells, B cells, and antibodies.
So this innate immune system acts immediately as soon as it detects a foreign body, and it does not, quote unquote, remember past exposures. The adaptive immune system components are very highly specific to particular targets, and they do have this, quote unquote, memory. If you've been exposed to something in the past, it, quote unquote, remembers that exposure, and you'll have the antibodies for that, and it'll mount that immune system response. Most immune fertility discussions focus on the innate immune system, especially cytokines and these uterine natural killer cells. On today's episode, we're focusing in on the cytokines.
So, what are cytokines exactly? Cytokines are small proteins that immune cells use to communicate with each other. They are a hormone-like substance produced by white blood cells or lymphocytes that communicate with and affect the responses of other cells of the immune system.
When you think about cytokines, you can think of them as almost like text messages between immune cells. Some of them are pro-inflammatory, meaning that they're going to cause more inflammation. And some of these text messages, quote unquote, or cytokines, are anti-inflammatory, and they're going to reduce inflammation in the body. When they are pro-inflammatory, what that means is that cytokines will recruit immune cells to perform more aggressive roles in fighting off infection or the rejection of foreign tissue. Again, in this case, that foreign tissue being a pregnancy.
Now, you'll often hear in the context of the immunity and fertility, you often hear about Th1 and Th2 cytokines. Th stands for T helper cells. So Th1 cytokines promote inflammation. They attack target cells that might be infected or recognized as abnormal. Th2 cytokines promote tolerance, and they tend to oppose the cytokines secreted by the Th1 cells.
Th1 cytokines include things like TNF alpha and IFN gamma. TNF stands for tumor necrosis factor, and this is a protein that causes inflammatory effects to the immune system. Interferon, which is often called IFN, is a group of signaling proteins that are made and released in the response to the presence of virus-infected cells. Th2 cytokines include IL-4 and IL-10. So IL, or interleukin, is an anti-inflammatory cytokine. In early pregnancy, it seems that there has to be a shift towards a Th2 dominant environment, especially at implantation. And elevated ratios, meaning of TNF to interleukin or IFN to interleukin, indicate an elevated immunological response and may lead to implantation failure.
So, what is the theory? Why do elevated cytokines matter when it comes to recurrent pregnancy loss and implantation failure? The hypothesis goes like this. The idea is that there is excess inflammation at the uterine level, and that might cause interference with implantation. It might disrupt placenta development, and it might contribute to early miscarriage or fail implantation altogether.
But, and this is really, really important, this is biologically plausible, yet not fully proven. Okay. So, what do I mean by that? It means that from what we know, based on studies, looking under microscopes, things that have been done in the lab, when we look at these particular cells, it's plausible, it's possible, it makes sense that this could be happening. That's why it's a good theory. But again, this has not been fully proven.
At the endometrium level, cytokines regulate essential reproductive processes, including trophoblast invasion. Trophoblasts are the cells that are going to become placenta, spiral artery remodeling, which are the arteries that need to feed the future fetus or the embryo that turns into a future fetus, and immune suppression, which again is necessary for the body to allow the embryo to implant and not recognize they have foreign. Studies in the lab have shown that when there is a Th2 biased cytokine mix, that seems to support pregnancy by promoting progesterone production and trophoblast or placenta function. While where there is an excessive Th1 cytokine, like tumor necrosis factor or interferon, that exhibits more of an embryotoxic effect. It is important to highlight that these findings were made in the lab, and the lab is never the same as the human body out in the world going through an embryo transfer. So, clinical studies that are actually studying patients with infertility going through embryo transfer really are needed to really understand if this hypothesis is true in the real world and outside the lab.
All right, so let's talk about how we test for these cytokines, and then we're going to talk about who should be doing this test.
There are several testing modalities available to assess cytokine levels in reproductive immunology, and that would be peripheral blood serum being the most commonly used. You can also try follicular fluid and cervical mucus, but those are not really used clinically very much.
At Markham Fertility Center, we prefer peripheral blood cytokine panel testing. Specifically, we do it through Rosalind Franklin University in the US. What they do is they will measure the ratio of Th1 to Th2 cytokines from the cytoplasm of these lymphocytes or white blood cells by a process called flow cytometry. The results that we receive back come back as a ratio. So we get two numbers basically. The first is a ratio of TNF alpha to interleukin 10, and the second is interferon or IFN, again to interleukin 10. You may remember that both of these are looking at the ratio of Th1 to Th2 cells.
It's important to point out that the clinical utility of this test still remains investigational. And I know I've said it before, but one of our biggest fears is that patients are taking these numbers as gospel in their reproductive care. And it's really important that these decisions and these tests are done with fully informed consent about what they really mean. So the clinical utility remains investigational as there is no standard references or validated predictive threshold that have been established through rigorous research. One of the major challenges is exactly that. There is no standard reference ranges. There could be day-to-day variability, and there is poor correlation between what we see in the blood and what we're seeing in the uterine immune environment at the time of implantation.
Now, logistically, let's say you're getting your testing done here at Markham Fertility Center. It's pretty straightforward. It involves a peripheral blood draw. Again, we do it any day of the cycle, and we're doing the blood draw from the person who is planning to carry the pregnancy. We then arrange for shipping of the blood to the appropriate lab where they do the testing, and we receive the results about 2 weeks later. Again, if we're doing testing for cytokines, we're probably doing testing for the full immune panel. That would include the leukocyte antibodies and natural killer cells, which we've talked about on other episodes in our immune series. Now, it's also very, very important to note that this testing is not covered by OHIP. If you're a resident of Ontario and you have health coverage from the province, this will not cover the test costs, and this is something that you're paying for out of pocket.
Patients often ask us, should I test my cytokines? And we're going to spend a little bit of time answering these questions right now.
Yes, because honestly, this is the most important question, I think,
Mhm.
out of all of this, right? Talking about what are cytokines is relatively easy, but who should be testing for them? This is the important stuff because this is really where things get controversial and this is where things get complicated. So, very generally speaking, we do not recommend this type of testing for patients who have zero history of miscarriages or implantation failure.
As with any immune testing, we have to start this conversation about reproductive immunology only after there is a clinical reason for doing that. And a clinical reason for doing that would be at least to fail euploid embryo transfers. But we do want to emphasize that there is no hard rules about this. And I know that sounds cruel. Gosh, you want me to fail before you test for something?
Mhm.
Hopefully, by the end of this episode, you understand that we're not being cruel and that there
Mhm.
is a reason why we do it this way.
When we are starting this discussion about immune testing or testing around cytokines, one of the things that we talk a lot about to patients, I talk about to patients, is what the evidence shows and what the research shows. And it's very important that people, when they're making a decision about whether they're going to do this or not, understand what that is. So we're going to spend quite a bit of time on this. First of all, it's important to say multiple systematic reviews and meta analyses have concluded that cytokine testing doesn't have the necessary evidence base for us to implement this clinically very broadly. Okay. So, again, when we've talked about research in the past, meta analyses and systematic reviews are basically studies that look at a number of studies and try and pool those conclusions to come up with answers. In fact, there was a systematic review just in 2025 that reviewed specifically, and what they said is that, quote, there is insufficient evidence to support the routine use of peripheral blood cytokine levels as diagnostic markers for RIF, recurrent implantation failure, or to guide immunomodulatory treatment. Now, a couple of key things. They talked about routine use of this. So, again, this should not be used for everyone routinely. And the review also identified that there were significant concerns about the quality of the studies that they looked at, the heterogeneity in RIF definitions, meaning that different studies will define who has RIF differently. And so then you're kind of comparing apples and oranges. There were also concerns about how they selected for control groups, meaning how these studies were done, and of course, the lab methodologies. Even though this study came out with this conclusion, you have to keep in mind that the studies that were used to make this conclusion maybe weren't the best quality studies. And therefore, that will affect how we kind of view or how we take this conclusion and what we do with it.
Yeah, so to summarize, what this means in the end is that the studies weren't great, and based on the evidence we have, is not recommended. But it's not because we have good evidence to say it doesn't work. It's because we just don't have any evidence to say it does work. And that is a
Exactly.
really important distinction.
Mhm.
I think if we had really good studies saying perfect studies, no issues with any definitions, and look, it really doesn't work, then I would have no problem never offering this ever
Yeah.
again. But that's just not what we have. What we have is a mixed mash of studies. Some say yes, some say not. You can't really put them together. You can't compare. And none of them has conclusively proven that there is evidence that this is not working for patients. One of the primary barriers to clinical adoption includes the lack of standardized reference ranges. So you got to start by defining something, and we can't really define it. So
Yes.
that's a problem. So there is inconsistent measuring protocols, like how do you measure cytokines varies between studies, the time at which you're collecting the sample. And while research studies have identified different cytokine profiles in both recurrent implantation failures and recurrent pregnancy loss patients, like I mentioned, including elevated in Th1 cytokines, which are pro inflammatory, and decreased Th2 cytokines, which are anti inflammatory, still, there is no real way to apply this to clinical scenarios, so it still remains investigational.
It's also very important to point out that there are currently no established clinical guidelines recommending routine cytokine testing in patients with recurrent implantation failure or recurrent pregnancy loss. Clinical guidelines are published by these big societies, the Canadian group of fertility doctors, an American group of fertility doctors, or a European group of fertility doctors. And they work together to review the research and they post guidelines that are going to guide physicians about what they should do with common diagnoses like RIF or RPL. In these guidelines, they have said that we should not routinely be doing cytokine testing. In fact, there was a 2025 SOGC Canadian guideline, that's the Society of Obstetricians and Gynecologists of Canada, on recurrent pregnancy loss. And they explicitly recommended against the testing of cytokines. Similarly, American Society for Reproductive Medicine, the European Society of Human Reproduction and Embryology, and the Royal College of Obstetricians and Gynecologists, they're in the UK, all advise against routine cytokine testing in their RPL, the recurrent pregnancy loss evaluation guidelines.
Once again, the rationale for excluding cytokine testing relates to the lack of evidence or insufficient evidence of the clinical utility. Insufficient evidence does not mean it is harmful. It does not mean it doesn't work. It just means we can't prove that it works.
Very, very similar story with RIF or recurrent implantation failure. Research has shown that there are altered cytokine profiles in RIF patients, that patients with RIF tend to have elevated pro-inflammatory cytokines and decreased anti-inflammatory cytokines, and therefore these increased Th1 to Th2 ratios. But there is not really that evidence there to support the routine use of peripheral blood cytokine levels to diagnose RIF or to guide immune treatments.
So this begs the $1 million question, why do we do it? We just talked about Market Fertility Center and how we do cytokine levels. Why do we test? Why do we treat elevated cytokines in our patients? We read the guidelines. We completely understand why the big guidelines group advise against it. We've seen the studies as well. And quite frankly, they are a mess. And if I was sitting in those guideline committees, I would probably come up with the same conclusion in terms of creating a guideline. The authors really did their best in trying to come up with an answer. And however, there are a lot of gaps in medicine, and the ideal study in the real world is going to be really hard to do. And in the meantime, our patients are suffering and they want answers and they want treatments. And we have a responsibility to come to them with truth, with informed consent, but also with options to help them.
Yeah, absolutely. And the purpose of these guidelines is to provide guidance that will be beneficial for the greatest majority of patients, right? Does that mean that the same advice or guidance will benefit absolutely everyone? No, of course not. Every individual is unique, as are their circumstances and how they got to be where they are. We generally offer cytokine testing treatment in these more outlier, exceptional type cases. This is why we really, really strongly discourage a routine testing of cytokines for everyone or before somebody's first ever embryo transfer. As you're listening to this, you may wonder, why shouldn't everyone be tested? I'd rather fix my problem before I have multiple failures.
Yeah, so although the testing is simple enough in terms of just doing a blood draw and sending it away, it is not covered by OHIP. So patients are paying out of pocket. And fertility treatments are very expensive, as we know. So as physicians, we have the fiscal responsibility on trying to get you the maximum pregnancy outcomes for the lower cost. As well, it takes time. So it will lead to delays in embryo transfer because now you got to do the testing, you got to get the results, and you got to do a treatment. And again, we know that delays in fertility care really impact outcomes very severely as well. And also, there is no guarantee that altered cytokines definitely improve the outcomes in recurrent pregnancy loss and recurrent implantation failure. So we can't just do it for everybody before they even have a problem when we're not sure that the testing that we're doing is going to solve the problem they haven't had in the first place.
Mm-hmm.
I hope that makes sense.
Oh, I get it.
I know you do.
Yeah, absolutely. And then, the other thing is that the treatments themselves may come with risks to the person who's carrying the pregnancy and potentially to the pregnancy itself and to the outcome for baby. And again, there's no guarantee that altered cytokines prove that you are going to have RPL or that you're going to have RIF. And so that is why we really, really discourage the routine testing of these things.
So that begs the question then. We talked about the guidelines. We talked about why don't we offer it routinely. We talked about why we spend more time telling people not to do it and we spend time actually doing these treatments. Yeah. But we do them.
Yes.
Knowing what we just talked about from the guidelines and knowing our concerns with the overuse of immune testing, why do we actually do it? Why do we actually do the testing and treatment at Market Fertility Center? We're famous for that.
What we sort of said a little bit before, the evidence is incomplete, right? The options are also very limited. When you actually go back and look at the guidelines for recurrent implantation failure and recurrent pregnancy loss, really, they basically say a lot of treatments that don't work. They don't really provide a lot of guidance in terms of what we should do or what the treatments are that do work. And oftentimes you can come away from those guidelines for saying like, well, we should just do a sono and do another transfer and just kind of keep going.
That's right.
I want to be clear. The guideline authors, I would come to the same conclusions. I probably would have written the same thing if I were a guideline author myself, because there are very, very limited evidence-based treatment options for RIF and RPL. We are sort of left with not much to work with. We don't have much in our toolbox. And immune testing and immune treatment may potentially yield positive results. And it may be the answer for some patients. Again, not everyone, because every individual and their case is unique. This is why we try and provide this balanced view, as this is a potential option. I always tell people, like, we're stepping outside of the box now. We're stepping past the guideline now. You have done all the things in the guidelines and the textbooks tell us to do, and we're still not where we want to be. So now we have to step past that, step out of the box and look beyond, right? And sort of see what's there. And that's why we have these big, long discussions about the evidence and what it shows and what the risks are and what the benefits might potentially be. Because it's not that the studies show that this doesn't work. It's just that we don't have good studies to show that it does work and for whom it's going to work best. And so in the current context of what we have, that's why we do it. We're always thinking about what the potential risks are, you know. The risks are for cytokine testing relatively low. This is very subjective. And we always have to consider risk to the person carrying the pregnancy, risk to the pregnancy itself, and risk to baby.
At the end of the day, it's all about patient autonomy and giving the patient options. I would never tell a patient, you need to do immune testing. Here's the answer. You know, I got the perfect solution for you, because that's just not the way it works. But we have the conversation. Listen, you've had 3 euploid embryo transfers. Your lining has been great. Your sonos has been done. All of the testing is perfect. The embryos are great as far as we know. You have 1 embryo left or 2 embryo left. I know that you cannot make more because of age, because of cost, because whatever it is. Now, like you're saying, we got to go outside the box. We got a bit of a gun to our head, so to speak, and we need to think about what we're going to do next. And after that conversation, sometimes the answer is just another embryo transfer. That's not the wrong answer by any means.
Absolutely.
But I do think that patients need to look at the big picture and not just, hey, I read a guideline that says let's do nothing, but look at the big picture, look at all the studies, look at the evidence, look at the lack of, look at the options. And then they, together with the doctors, can make decisions that at the end of the day feels empowered to their journey and feels that, hey, it's an imperfect science, but I was able to explore any possibility or any options that would give me a better chance of success.
You said something there that I think is really important, because patients deserve honesty, not certainty where none exists. And there is no certainty around this when it comes to immune system, immune treatments, and cytokines. So let me be clear. If you have listened to all of this and you appreciate that this is not a quote unquote quick fix or a guarantee, then you are on the right track. I think the key point is shared decision making. None of us have a crystal ball. And in an embryo transfer, there are millions of variables. We can maybe test for, 5 of 6 of them. So really, we are doing the best we can with the knowledge we have, and we're making decisions together.
Yeah, that is exactly right. And it is the tightrope that we walk with our patients every single day. And it is really an honor to do it. And my fear is that patients feel that we are giving them false hope. And my fear is also that patients feel we're not giving them options.
Yes.
Right? So we got to do a little bit of both.
Yeah.
Thank you so much for listening. Stay tuned for the next episode as we continue our series on the immune system. In the next episode in this series, we're going to talk about treatments for elevated cytokines.
Yes, there are definitely many treatments out there. Some of them work, some of them don't work. Some of them also carry risks. So we're going to go through all of that stuff as well.
And that's a wrap for today, Superhumans.
If you're looking to connect, get social with us. Follow us on YouTube and Instagram at My Fertility Podcast or visit us online at mycanfertility.com. And don't forget, follow, subscribe, and share your favorite episode.
Thanks for listening to My Fertility Podcast and for being a vital part of our community. We know you've got this. If you found this episode of My Fertility Podcast helpful, please take a moment to head over to the review section and leave us your thoughts. Your reviews and comments are incredibly valuable to us and help guide future episodes. We also welcome you to direct your questions to info@myfertilitypodcast.com.
My Fertility Podcast is produced by Rabbit Media Inc. in conjunction with Dr. Garcia and Dr. Weiss. Music, Island Memories, instrumental by Descript stock music. My Fertility Podcast is not intended to replace any type or variation thereof professional medical, health, or legal advice, nor should the content be taken as medical advice. Please contact your primary healthcare professional regarding any medical questions you may have. The information presented in this podcast is based on the knowledge and understanding of the host at the time of recording. Medical knowledge is constantly evolving, and new research may change the understanding of health-related topics. While we strive to provide accurate and up-to-date information, we do not guarantee the completeness, accuracy, or timeliness of the content. The views expressed in this podcast by guests are not those of the host or the management. This podcast is not intended to impose any type of discrimination. My Fertility Podcast and its management are not responsible for any losses, damages, or liabilities that may arise from the use of this podcast.